Kiana, take it away.
Good evening and welcome to the 71st session at Virtual Shadowing. My name is Kiana and I will be your host this evening. Tonight I am joined by a very special guest, Dr. Fagenbaum, as he describes his journey to chasing his own cure. As always, if you have any questions or concerns, feel free to reach out to us at virtualshadowing@gmail.com. Also make sure to check out our Instagram and join our mailing list in order to be informed about future sessions. Could you go to the next slide, please? Here's our virtual shadowing group, which consists of Reagan, Cheyenne, Taylor, Ali, Rachel, Miriam, Elena, and Ruth, myself, and Aditya. We also have our leading physicians, Dr. Fowler, Dr. Moschetti, Dr. Salazar, and Dr. Reno. Next slide. Here are our upcoming sessions. This session will be our last for the month of September. Next month, we will have a specialty spotlight in trauma and acute care surgery on October 5th, emergency medicine October 12th, inside emergency medicine October 19th, and finally a specialty spotlight into urology on October 26th. Each of these can be seen on Zoom or YouTube live at 7 p.m. Central Standard Time. Next slide, please. And then as always, we'll have 2 question and answers throughout this presentation. We'll have one in the middle and then one towards the end of the presentation. So make sure to put your questions in the chat box below if you have any questions at any time. Dr. Fowler, do you have anything for us?
Well, welcome everybody. It's so good to have you for our 71st session. If you can believe that we've been going this long, it's so good to have you back. It means a great deal to the whole virtual shadowing team and to our guests this evening that you would come from all over the world, from Texas to Qatar and all places in between. And so we welcome you here. As many of you know, I'm on the admissions committee here at UT Southwestern, and we've already had 4 meetings now, and I'm definitely seeing many applicants who are using virtual shadowing participation as part of their documentation of their pre-healthcare participation as they plan their paths for the future. So welcome. As we've said all along, as long as you keep coming back, we're going to be here, but you got to keep coming back. But it's been great sessions. And tonight we have an especially magnificent speaker and guest and physician and someone who has got a great message to send to us. And so without any further ado, Kiana, would you introduce our wonderful guest for this evening?
Of course. Dr. Fagenbaum is a physician who became his own patient in his battle with the rare form of Castleman disease. His story is not only remarkable, but inspirational, and I am so excited he is here with us tonight. So without further ado, please take it away, Dr. Fagenbaum.
Kiana and Ray, thank you so much for the introduction and for having me today. I've been so impressed to hear about this virtual shadowing program and really thrilled to have the opportunity to share with all of you today. So I titled my talk Chasing My Cure, but I really want this to be an interactive session where you guys can throw questions into the chat. We'll have some time in the middle to answer those questions. We'll also get to questions towards the end. Really, it's an opportunity to share about my journey chasing my cure and really the lessons I learned along the way about life, about medicine, about hope, for my journey and nearly dying 5 times. So I think the title of my talk will make a little bit more sense as we move through. But just some quick background on who I am today. I'm an assistant professor of medicine and translational medicine and human genetics at the University of Pennsylvania. And I'm the director of the Center for Cytokine Storm Treatment and Laboratory and the associate director of Penn's Orphan Disease Center. I suspect that most of you all had maybe not heard about cytokine storm until this past year and a half when COVID emerged, but it's an area of really intense research in the immune space that I'm really thrilled to be a part of. So I want to start out first as a 3rd-year medical student. This is a picture of me at the University of Pennsylvania, where I was training to hopefully become a physician and treat patients in memory of my mom. She had passed away just a few years before, and I was on a mission, on a path to become a physician, to treat patients in her memory, when out of nowhere, I became critically ill and became a patient myself. So This is me in the exact same hospital that I've been treating patients in just weeks before, experiencing multi-organ system failure. My liver, my kidneys, my bone marrow, my heart, and my lungs were all shutting down for an unknown cause. We had no idea what it was. And without knowing what it was, we didn't know how to treat me. And I became critically ill. In fact, I was so sick that my doctors told my family that I was not likely to survive. And a priest came into my room and read my last rites to me. I said goodbye to my family, my dad, my sisters, and I prepared literally to not be alive any longer. I've really considered that moment, really when I hit my lowest point, when the doctors didn't think I would survive, to be the start of my overtime. The concept of overtime, I think, is something that anyone will understand if you're a sports fan, this idea that in overtime, every second counts. It's time you didn't think that you'd have. You can make a mistake in the first quarter and you can make up for it. But in overtime, there's an intense sense of focus and clarity. And so I really feel like I'm in overtime right now. And as was mentioned earlier, I wrote a book about my journey called Chasing My Cure, which came out a couple of years ago. And throughout my talk, I'll be sharing passages from the book that I think really resonate with aspects of my story. So the experience of being in overtime is surprisingly one of intense awareness and scrutiny and clarity. There's a reason for that. When there are only a few seconds left on the board, all distractions disappear and the purpose, victory becomes clear. The present is only the things around you, and overtime is all present, nothing but present and purpose. And as I mentioned, I've been living with this sense of overtime because obviously I'm speaking to you today. So clearly I survived, but I so appreciate every second, and it provides clarity how I spend my day. So today I'm going to talk through my journey, kind of what happened after that moment of overtime, some challenges for Castleman disease and other rare diseases, some progress that we've been able to make, then the concept of personalized medicine or precision medicine, which I'm sure all of you have heard about, and close with some lessons learned. But considering this is a virtual shadowing sort of session, please do throw your questions and comments in the chat. Let's make this a two-way conversation. So if overtime started for me when I was 25 years old in medical school, then I've thought back in my life, and this is part of writing my book, I had to think about these sorts of things. What was the first half of my life and what was the second half? If overtime started when I was 25. And so as I look back on my life, I really feel like the first half of my life started, or first half of my life was from the time I was born until I was about 18 years old. And during that first half of my life, I dreamed of one day playing college football. I grew up in Raleigh, North Carolina. Both of my parents were born and raised in Trinidad in the Caribbean. And so they came to the United States, and I was born here in the US as a first generation American. And as a child, I loved football, and I dreamed of playing college football one day and quarterback. And that was really kind of everything I worked towards was this idea that, one day I could play college football. And fortunately, I had an opportunity where I was offered the opportunity to play football at Georgetown, which for me, I was really excited about because it was both a great opportunity for me to play Division I football, but also a great academic school for me. And so I really kind of achieved that dream in the first half of my life. I was going to play college football, and I was going to a school that I was really excited about. And this picture here is of my mom and I on the day that I graduated from high school. And, so excited to achieve this dream and really kind of feeling on top of the world when my life just completely turned upside down just a couple of weeks later. And I really consider the moment that my mom was diagnosed with cancer, which occurred just a couple of weeks after I graduated from high school, to be almost half time of my life, of my life and who I am and what I do. So shortly after her diagnosis, my mom went to Duke for brain surgery. And I remember immediately leaving Georgetown to go down to Duke. And I remember walking through the lobby at Duke at the Brain Tumor Center and seeing a sign that said, "At Duke, there is hope." And I remember feeling hopeful that maybe, that there would almost be a miracle, that these doctors would be able to treat my mom's brain cancer, that she would survive longer than anyone had ever survived before. And I remember truly feeling hope, knowing that we were at the best brain tumor center in the world. my mom brain surgery, and this is a picture of her and I just a few months later. She had lost her hair from the chemotherapy. This is her a wig, but we were just so thankful for every moment that we had together. My mom survived for about 15 months after her diagnosis, and through time, I spent every week back home with her and tried to really spend as much time with her and enjoy every moment. During that time, I also became really passionate about going into medicine. I decided that I wanted to treat patients like my mom. That's what I wanted my life to be focused on. And I also decided that I wanted to start an organization in her memory. My mom, her name was Anne Marie Feigenbaum, and shortly before she passed away during my sophomore year of college, I promised her that I would start an organization in her memory. I said, Mom, I'm going to call it AMF. It's going to be for grieving college students. I don't know what AMF will stand for, but those were her initials, Anne Marie Feigenbaum. And so I made this promise to her. She passed away shortly thereafter, and I was just completely devastated when I returned to Georgetown, but I was also on a mission. And I began and created this organization called Students of AMF, which stood for Ailing Mothers and Fathers, in addition to my mom's initials. And it provided a support group for college students to connect with one another, and also a service organization to raise money and awareness for causes that were important to members of our group. So raising money and awareness for brain cancer, for example. Shortly thereafter, starting AMF at Georgetown, students from other campuses reached out and said, I've recently lost my mom or my dad or a family member, and I want to start an organization or a chapter of AMF on my campus. And we eventually started a nonprofit organization called National Students of AMF to support launching these chapters of AMF all over the country. And we were able to raise tremendous awareness and really keep my mom's legacy around. In fact, back in 2008, my face was on the back of 40 million bags of Doritos as a way to raise awareness for AMF. And it's actually amazing how many bags of Doritos college students eat, because it actually resulted in tons of new chapters of AMF all over the country. But in addition to just getting the word out there through things like Doritos bags, there was also just this tremendous awareness around college campuses around the country that grief was an issue and that we needed to provide resources for grieving college students. During college, another major milestone occurred, and that's that I met my girlfriend, Caitlin. We started dating my senior year of college and dated for a few years before or while I was in medical school. I went to grad school at Oxford, and then my first couple of years in medical school. And a little bit into my second year of med school, we decided to take a break. We dated for 3 years, and we felt like, we're 25 years old. We've got all the time in the world. If this thing is meant to be, it's meant to be, and it'll work itself out. And then just a couple months later, I found myself in the ICU literally dying with multi-organ failure. And I realized I didn't actually have all the time in the world. And I really regretted that I had lived a life where I kind of assumed that, if it's meant to be, it's meant to be. And so I promised myself that if I were to survive in the hospital, that I would no longer live with this idea that, we'll see what happens. If it's meant to be, it's meant to be. As I shared, I then ended up going to medical school, and shortly thereafter, became very, very ill. So fast forwarding back to while I was very ill in the hospital, and shortly after having my last rites read to me, my dad got the cell phone number for a doctor at the NIH. At this stage, I'd spent weeks in the hospital, no diagnosis, no one knew what was literally killing me. And a family friend gave my dad a cell phone number for a doctor at the NIH. And my dad didn't know who this doctor was, but he thought he would call him and maybe this doctor could give my dad some answers. And so every day for about 4 weeks, my dad would call this doctor, tell him all of my lab tests, what was going on, and the doctor would provide feedback on what he thought was going on, the tests we should run, what we should consider. And about 6 months later, when I was finally discharged from the hospital, I said, Dad, when I first got sick, I remember you were calling someone and speaking to someone on the phone every day for a week. Who's that doctor? He said, son, I don't remember. I think his name's Fucci, and I think he's at the NIH. You should Google Fucci NIH and see if we can figure out who this is. And so then I realized and I learned that it was actually Tony Fauci, who my dad had been calling every day for weeks while I was in the ICU. And I shared this story for a couple of reasons. First off, my dad should have known who Dr. Fauci was. He actually had already won a Presidential Medal of Freedom from George W. Bush. But the real reason why I share this story is that loved ones of patients will go so far to do anything they can for the people that they love. My dad would have swam across the Atlantic Ocean. He would have hounded any NIH director if it meant that it could have helped his son. And so as you guys go into medicine and as you become physicians or healthcare professionals, it's important to never forget about the loved ones, the parents, the siblings, the children. They are just as much part of the patient journey as the patient is. So there's a lot of focus on patient engagement, but let's not forget about the loved ones and people like my dad, who don't take the time to figure out who someone is and call someone by the wrong name, like he used to call Dr. Fucci. So despite Dr. Fauci's best efforts and suggestions, the doctors continue to struggle with what to do. But eventually, as I got worse and worse and worse, and as I shared, a priest came into my room and read my last rites, I knew that I was at the very kind of end of my road. And I want to share what I really think was kind of a low, really not kind of, was the low point in my life. And that was when I knew that I wasn't going to survive for more than a day or two. We had no idea what this disease was that was killing me. And I just wanted to give up, frankly. I was in so much pain. I'd gained about 70 pounds of fluid around my body because my liver and kidneys had stopped working. So fluid was just everywhere. And it was so painful. It was almost like getting stabbed simultaneously all over my body. And I was just ready to give up. I could not fight anymore. I just wanted to give up. And I remember for a split second looking over at a telephone cord or telephone in the hospital room. I remember thinking for just a split second, it wasn't any longer than that, but gosh, I wish I could physically reach over and grab that cord and just put an end to this whole thing. Thankfully, that sort of a thought lasted so briefly. And I immediately thought to myself, I've got to keep fighting. Even if I'm going to fight for one more minute of life, I've got to do it. My dad, my sisters, they haven't left my side. I can't give up. I've got to keep fighting. But I share this story because, if you read Chasing My Cure, if you hear a lot of parts of my journey, it may sound like it was just a lot of chasing after treatments and cures and a lot of highs. And there certainly have been a lot of highs, but there also have certainly been a lot of lows. And this was definitely one of them when I just really wanted to give up. But I decided I wanted to keep fighting. And at this stage, I realized I had the simple realization that the regrets that ate at me the most as I prepared to die weren't about anything I'd done. My greatest regrets are things that I'd thought of doing but never did. It's the absence of memories that you wished you had made and the realization that you'll never get the chance to make them that for me was so difficult. And that's where I just committed to myself that if I were to survive from this, I would live a mentality and live a life of think it, do it. Things that were important to do, I would do. Thankfully, right around that time, a lymph node biopsy was performed. The doctors thought I had aggressive lymphoma, so they cut out one of my lymph nodes. But when the pathologist looked at the lymph node, they didn't see lymphoma. What they saw was evidence of something called idiopathic multicentric Castleman disease, which is a very rare immune system disorder where basically the immune system becomes hyperactivated and then begins to attack your vital organs for an unknown cause. We don't know whether it should be called a cancer or an autoimmune disease. There are features of both. And really, it's this sort of enigmatic disease with more questions than answers. But this is a picture of my lymph node, and the pathologist looking at it noticed a particular morphological appearance to the lymph node that made them think that this was idiopathic multicentric Castleman disease. So what is Castleman disease? Well, it was named after Dr. Benjamin Castleman, who's photographed here on the right side of the screen. Dr. Castleman described the disease for the first time ever back in 1954. And he really described it as a disease that's like lymphoma, but when you cut a lymph node out and look under the microscope, it has a particular appearance to the lymph node. It's not lymphoma, or it doesn't look like lymphoma. It looks like something different. And so it was described first in the 50s. But unfortunately, very little has been learned as the decades have gone on. We do know that Castleman disease has a few different forms. There's what's called unicentric Castleman disease, where you have a single region of enlarged lymph nodes. And if you cut out those lymph nodes, the patient is cured. And then there's what's called multicentric, where you have multiple regions of enlarged lymph nodes. And by the way, the lymph node is the home base for your immune system. When your immune system is in a fight or attack mode, your immune cells go to your lymph node to communicate with one another. And so if you get a vaccine or you get sick with something, your lymph nodes enlarge because your immune cells are going there to communicate with one another. So when we see enlarged lymph nodes in Castleman disease, that's because our immune systems are highly activated and the immune cells are getting out of control and they go to the lymph node to communicate with one another. So in multicentric Castleman disease, you can have MCD caused by a virus. A virus called HHV8 can turn on the immune system, and then the immune system gets out of control trying to fight the virus. You can also have MCD due to a cancer, something called Poem syndrome, where there is no virus, but there is actually a true cancer, a neoplasia of plasma cells. And it's those cancer cells that are actually turning on the immune system, and the immune system gets out of control. Then there's a third form of MCD, what's called idiopathic multicentric Castleman disease, where there's no virus and there's no evidence of cancer, and the immune system is completely out of control for an unknown cause. So we call it idiopathic, meaning the etiology is unknown. Idiopathic multicentric Castleman disease, that's the form of multicentric Castleman disease that I have, that I'll be focused on. So just to give you a bit more info about IMCD, about a third of patients with my disease die within 5 years of diagnosis, and another third of patients will die within 10 years of diagnosis, which is similar to the mortality associated with cancers. If you combine all cancers together, about 1/3 of cancer patients will die within 5 years. So similar sort of mortality as cancers, but a lot of overlap with autoimmune diseases, inflammatory conditions. We really don't know how to classify it, but it is a rare disorder, which means that only 5,000 patients are diagnosed each year in the US with a form of Castleman disease. Now, 5,000 patients a year is obviously quite rare, but for perspective, that's about how common ALS is. So Lou Gehrig's disease, or ALS, which of course has much more public awareness, also is diagnosed in about 5,000 patients each year here in the US. So there are a lot of these rare diseases like Castleman's that don't have the same sort of public awareness as ALS does. So I'm going to share with you a bit more about what is IMCD, how does it work, what goes on. I'm going to start out with a diagram, and please do continue to throw questions and comments into the chat. So when we think about idiopathic multicentric Castleman disease, patients get flu-like symptoms like I described. They get liver dysfunction, kidney dysfunction, their bone marrow shuts down, and the lymph node shows these particular features. And so you get really, really sick. If you can imagine the sickest patient you've ever seen in the hospital, maybe they're in the intensive care unit, that's what a Castleman disease patient looks like. That sort of clinical pathological picture, like what does the disease look like? That's been pretty well described for many decades. But it wasn't until this amazing researcher in Japan named Kazuyoshizaki discovered that interleukin-6, one particular cytokine, so your immune system has hundreds of cytokines, and each one of those cytokines plays an important role in fighting off different things like viruses or bacteria. The same cytokines also help immune cells to communicate with one another. Out of the hundreds of cytokines, it turns out that interleukin-6 is very elevated in patients with idiopathic multicentric Castleman disease. And Kazu discovered that. But even after he discovered that interleukin-6 seemed to be important in Castleman disease, there's been kind of a black box around, well, why is the IL-6 elevated in the first place? What are the signaling pathways within immune cells that are causing the IL-6 to be elevated? Which immune cells are the ones that are producing the IL-6? And what's causing this whole thing to start in the first place? Is there a virus that we just haven't discovered? Is there a population of cancerous cells we haven't discovered? Are there autoimmune mechanisms or autoinflammatory mechanisms? We don't know. All we know is that a patient like me can go from totally healthy medical student to dying in the intensive care unit in a matter of days, and we don't know why. But the most important thing to remember is that thankfully, because we learned that interleukin-6 was important for a portion of patients, we know that if you block interleukin-6, that 1/3 of patients will have their disease disappear. It's incredible. Give an IL-6 blocker, a drug called siltuximab or another one called tocilizumab, and the disease just melts away. You go from being in the ICU to getting out of the ICU and literally, walking out of the hospital. Unfortunately, for about 2/3 of patients, IL-6 blockade doesn't work. So you can block with ciltuximab or tocilizumab, all the IL-6 you want, but you don't get better. And so I fall into that category. And what's tough about being in that category is all of a sudden you have an unknown cause in an unknown cell type with an unknown signaling pathway and unknown cytokines. And then what do? How do you treat a disease like this? One thing you could do is to just give up and say, look, I don't know what to direct my treatments against because I don't know what's going on here. Another option, which is what we do in Castleman's, is to use chemotherapy to just wipe out the whole immune system. So if you don't know what immune cell to target, you can just kill them all with chemotherapy. And so that's what we do. We give a combination. In my case, I got a combination of 7 different chemotherapies, really at the maximum tolerable doses, to completely obliterate my immune system. And that's what saved my life. Unfortunately, it's not a durable response. It's what's considered kind of a short-term lifesaver. But I mentioned Kazuyoshizaki, and I wanted to share a little bit more about Kazu. This is Kazu and I doing what we call the Castleman Flex. If we were all in person together, I would ask all of you guys to stand up and do a Castleman Flex. We get a picture together of all of us doing it. But in the absence of being able to do that, I hope maybe you guys will take a picture doing the Castleman Flex, maybe throw it on social media with the hashtag Castleman Flex, Castleman Warrior. But this is the ultimate Castleman Warrior, Kazuyoshizaki. He was the person who discovered that interleukin-6 was elevated in Castleman disease. And amazingly, he went on to develop a drug that targets interleukin-6 called tocilizumab. He developed it just for Castleman's in Japan. And I heard a rumor from a friend of mine, Makoto, who works with Kazu. Makoto said, David, not only did Kazu discover interleukin-6 as being elevated and develop tocilizumab, he actually gave it to himself to prove that it was safe. And I said, there's no way that could be the case. And I asked Kazu, I said, Kazu, is it true that you gave tocilizumab to yourself as the first human ever to get this drug? He said, no, I didn't give it to myself. The nurse gave it to me. I said, exactly, Kazu. So he made the discovery about what should be targeted. He developed the drug, and then he gave it to himself as the first human to ever get tocilizumab. And he didn't die, so he went on to develop it further. They went on to test it for Castleman disease. It got approval in Japan for Castleman disease. And then when a different drug company purchased it, they took it here to the United States and tested it for rheumatoid arthritis. It got approval here for RA. And then, as you all may be familiar, tocilizumab has also been used in a number of other settings. This is a picture of Emily Whitehead. She is the first pediatric patient to ever receive something called cellular immunotherapy, which is basically where you take the immune cells of a patient with cancer, you take it out of their body, you supercharge them, direct them against the cancer, and then put them back in the body. And in the process of doing that, those immune cells will kill the cancer, but they can also make the patient really, really sick. And they create a cytokine storm that looks like Castleman disease. So when Emily got the first dose of cellular immunotherapy and she was dying in the ICU with something that looked like Castleman disease, her doctors gave her tocilizumab. They gave her the drug that Kazu developed for Castleman's decades before, and it saved Emily's life. And in the process of saving Emily's life, not only was that so important for her and her family, but it saved the entire cancer immunotherapy program, because if the first pediatric patient to ever get cancer immunotherapy died, then that would have completely halted the whole program for at least a decade. But because this drug, tocilizumab, which was made for Castleman disease, repurposed for cellular immunotherapy, because it saved her life, that kept what really is one of the most exciting and promising areas of all of cancer research alive.
Well, David, tocilizumab is being used for COVID, or at least as a trial, right?
Ray, you have foreshadowed my next click. You're exactly right.
I'm so sorry. Oops, sorry.
Perfect. No, perfect timing. Absolutely. So, when this pandemic emerged and we learned that patients were experiencing what's called a cytokine storm, which is basically where your immune system gets out of control, happens in Castleman's. It turns out it also happens in the most severe COVID patients. Doctors around the world started saying, hey, we should try this tocilizumab drug. Most people don't remember that it was developed for Castleman disease. They think about it for RA. But so doctors started utilizing tocilizumab all around the world. And there were a number of anecdotal reports of how tocilizumab was helping people. There was kind of some data that suggests that maybe it wasn't as helpful as we hoped. But then more recently, a number of large studies that have really definitively shown that tocilizumab, if given at the right time, is a lifesaver for patients in the ICU. So just as Ray mentioned, if you give this drug to patients within 24 hours of admission to the ICU for COVID-19, you will reduce mortality by about 15 to 20%. So this is just a great example. And I'm so glad you foreshadowed that comment, because this is truly the first drug you'll get if you're in the ICU for COVID.
So do we think we know specifically where tocilizumab is working? Is it an IL-6 inhibitor, or what's it doing?
That's exactly right. Tocilizumab inhibits the receptor for interleukin-6. So it basically completely binds all the receptors for IL-6. So then your IL-6 can't do its job, which in the setting of COVID or Castleman's is a bad thing. You don't want IL-6 signaling.
So if I understand it correctly in layman's language, tocilizumab and similar type drugs prevent the body from attacking itself, something like that. Is that correct?
That's right. And I think a really important point, and I'm glad you're bringing this up, is that when we think about COVID or any other sort of virus, truly, and really in any setting, we think the immune system is only there to do good. And we think that the immune system is there to protect you from things like SARS-CoV-2 and other viruses. And that is true. The immune system is there to protect you. However, in the immune system's attempt to fight off things like SARS-CoV-2, it can actually create a lot of collateral damage. And actually, in the process of clearing the virus, it can actually cause a lot of damage and actually kill you. So in the most severe cases of COVID-19, the problem isn't the virus. The problem is that you're having an overexuberant response to the virus. So a drug like tocilizumab is actually going to calm down your immune system. It's going to suppress the right part of the immune system, so that way your immune system doesn't cause more collateral damage.
It seems to me, as I recall from Barry's book, The Great Influenza, that was kind of how the pandemic flu of 1918 seemed to cause terrible damage. And the healthier you were with a healthier immune system, the more likely your immune system would attack yourself if you got infected.
You're absolutely right. And thankfully, here with SARS-CoV-2, we haven't seen this high death rate among young people like was seen in 1918. And you're exactly right. But unfortunately, for a small fraction of people that get SARS-CoV-2 infection, their immune system has this overexuberant response. And what it looks like is that one of the reasons that this happens with SARS-CoV-2 is that the virus is very, very good at hiding itself in the first 5 to 7 days that it infects you. And so for 5 to 7 days, it basically evades the immune system, and it infects your entire respiratory tract all the way down into your lungs. And during that period, your immune system doesn't even know it's there. And by the time by day 5 or 7, the immune system becomes aware that the virus is present and it turns itself on, it's so behind the 8 ball that the immune system basically goes from 0 to 60 in 1 second. And in doing so, now is hyperactivated and is kind of behind the 8 ball.
So tocilizumab blocks the secretion of IL-6 or the receptor for IL-6, or do we know?
The receptor for IL-6. So it basically prevents the IL-6 from doing harm. So you've still got a lot of IL-6 in your body, but the IL-6 can't bind to the receptor. So it can't cause any more inflammation or any more immune activation.
Thank you.
Yeah, absolutely. And I'm very biased because of my connection to Castleman disease, but I just think this is such an important example for all the viewers of how research for a very rare disease, Kazu, did all of his research into idiopathic multicentric Castleman disease in Japan. He made this drug for IMCD, and here we are 30 years later, and it is the drug that you get in ICU for COVID.
Well, the ivermectin story is similar. It was isolated, I believe, in Japan from it was in the Far East from streptomyces, ivermectin, and for which I did not realize until this week a Nobel Prize was awarded in 2015 for ivermectin. But the question remains, does it really have consistent antiviral properties within the range of what the humans can tolerate at the right dose level?
Yeah, I mean, in vitro, it's really very effective. But like you said, there's a concern that there's about a 10-fold difference in the concentrations you can get with cells in a dish versus what you can get in humans. And I will say I'll mention this later in the talk. We run something called the Corona Project, which is the world's largest database of COVID-19 treatments. And our goal with this was to say, we want to put all the data in one place so anyone and everyone can look at it and play with it. And it's not this sort of kind of behind a curtain that it feels like for so many people. And so we've made that data publicly available. And I can tell you that from ivermectin, there absolutely are studies that suggest the benefit, but there are also studies that suggest there's no benefit. And so that's a tough one, whereas there are other drugs where it looks to be more consistently positive. Ivermectin is one of the tough drugs where there's really been a mixed set of results.
It was interesting. I looked at PubMed a couple of nights ago just to see where we were at in ivermectin. And, PubMed does everything, in terms of their articles, as you well know, all the way to last week. And there was nothing since January on ivermectin and PubMed and COVID. Kind of interesting.
Yeah, and I'm going to put a link in the chat for everyone, so you can go to the Corona Project. Basically, this is all of the world's data on treatments for COVID-19 in one place, freely available to the world to use. So with that sort of background, what is Castleman's? What is a cytokine storm? Now we'll dive back into my story. And so, as I mentioned earlier, I didn't respond to IL-6 blockade. That drug, siltuximab, which is kind of a second generation of tocilizumab, didn't work for me. And so I needed combination chemotherapy. I got adriamycin, Cytoxan, etoposide, Velcade, Dex, thalidomide, Rituxan, which completely obliterated my immune system, but in doing so, saved my life. And so you can see me sitting up and smiling next to my dad. I'm so thankful to be alive. I got my dad by my side. Of course, he was by my side throughout the entire experience. And you can see that I lost my hair from the chemotherapy. You can see I've still got my big belly from the liver and kidney failure. And I was, I guess, sporting masks before it was cool. This is about a decade ago. But my dad and I went for a walk on New Year's Eve 2010. This is actually in Little Rock, Arkansas, which I know that there are at least a few attendees from the Little Rock area. So we went for a walk around the hospital in Little Rock, and it was New Year's Eve. And you can see I've got this huge belly because my liver and my kidneys weren't working. And as we passed the family waiting room, we saw that there was a guy who had clearly been drinking on New Year's Eve. He was visibly drunk. He was like swaying in his chair. And in our next lap around the hospital, we saw that he had fallen onto the ground. And so my dad ran over to this drunk guy and helped him back into his chair. He looked at my dad and I, and he said, "Thanks so much. Good luck to you and your wife." He said, "Wife, what is he talking about?" And then I looked at my belly and I realized that he thought that I was my dad's pregnant wife and that we were walking laps to deliver our child on New Year's Eve, which was a low point emotionally for both of us. But I turned to my dad, I said, "Man, Dad, you've got an ugly wife." And we burst into laughter. And I think that, in the midst of really tough times, whether it's applying to medical school or it's medical challenges you face, laughing with the people you love, I think is really important.
David, we took a vote in chat real quickly, and we decided we liked the crew cut.
You like it? Thank you. I appreciate that. I appreciate that. So, with that sort of concept in mind of, laughing with the people you love, a quote I wanted to highlight is facing my horrible moments with laughter was just as fundamentally a rejection of Castleman's dominion over me as anything else I was doing. It cleared my mind. It stiffened my resolve. It was entirely up to me to determine what was and what wasn't funny. Perhaps most important, humor is social. For me and my family, there was never a better way to reset our collective resolve than laughing together.
David, I got to meet briefly Arthur Brooks lately, formerly the president of the American Enterprise Institute, widely published author, great writer. And he wrote a wonderful article about sort of the end of life generally, which I'll send you, he wrote a couple of years ago, and I reread it recently, and I sent him a note, and he wrote me back this week. He is up at Harvard now, and he wrote another paper this week about the difference between hope and optimism. Optimism being sort of a general attitude, but hope being this connection to the almost undefinable. That is something that connects to the depths of our subconscious and permeates all the way through, as you say, to that laughter, which lifted your spirits and maintained your emotional strength.
I love that. And I'd love to read it. I mean, in Chasing My Cure, I talk a lot about hope and how there are many forms of hope, at least in my opinion. There's the kind of hope that helps you to keep fighting because you believe and you hope for a different future than your present. There's the kind of hope that that, as you said, gets you to laugh in the midst of a tough time. There's also a kind of hope that I talked about quite a bit, and that's sometimes we can be so hopeful that it actually will prevent us from taking action because we have such a belief, or maybe it's an optimism, that it'll all work out, that we don't take action. That'll actually stop us from taking action. But I think what's important is when you can use hope to inspire action. So belief in the future, belief in something to actually get you to do things. Because I think that hope without action is certainly not nearly as powerful as hope with action. So, here you can maybe see why someone would have thought that I was my dad's pregnant wife. I had, this huge belly. I was, not looking my finest for sure. But I also wanted to show you guys a picture from just a couple years before when I played college football at Georgetown. And I always say these are the worst before and after pictures of all time. But if we could flip the order, it could be like this great advertisement for Muscle Milk or Peloton or the Mirror. But unfortunately, the pictures are in the wrong order. And unfortunately, I don't look like I did when I was a college football player.
Well, David, it seems to me the picture on the left is Peloton and the picture on the right is a beer commercial.
Yeah, that's exactly right. Yeah, wow. Unfortunately, I look a little bit more like kind of right in between the two these days. And I've really embraced my dad bod more recently.
Well, there you are.
So I took a picture every week for the next 8 weeks, and you could see how my fluid started to go away, my hair started to grow back, and by the end, I look a little bit less like a pregnant woman. Took pictures from the side as well, and again, you can see the fluid going away. I was getting tapped in my belly, so fluid was getting taken out 3 times a week. Between 5 and 7 liters was being tapped 3 times a week because of the tremendous amount of ascites. But with chemo and with treatment, we could get to a point where I no longer needed these paracenteses.
Well, it looks like you started working out again too.
I did. Yes, I did. So it was a combination of chemotherapy and exercise. Early on, it was just walking. Walking was the most intense working out I could do. So I spent almost 6 months hospitalized. And so I was just in terrible condition. But yeah, I mean, just literally walking laps in my kitchen was like my exercise for the day. And it was what I needed to start feeling better. So when I got out of the hospital, the first thing I did was reach out to Caitlin and tell her that I'd regretted that I hadn't fought for our relationship and really, didn't feel like it was the right thing to do, to just kind of believe if it's meant to be, it's meant to be. And I was really thankful to find out that she really felt the same way, and that she had also, while I was so sick, had also really, wished that we were still together. And I won't be able to get into all the details during our chat tonight, but my editor for Chasing My Cure really dug into a lot of the emotional challenges that Caitlin and I went through. Caitlin actually came to the hospital a number of times when I was really sick, but I didn't want her to see me like that, so I actually pushed her away a few times. So that's all details that you guys can get if you check out Chasing My Cure. So I love the picture on the left because I'm a huge Borat fan, and this is the first Halloween after we started dating again. And I hope everyone watching immediately, A, recognized that I was dressed as Borat, and B, knew who Borat was, because it would pain me if you guys didn't know who Borat was. But the picture on the right is actually probably my favorite picture of Caitlin and I. And that's from also Little Rock, Arkansas. I was going out to Little Rock every 3 weeks to get this experimental drug, siltuximab. And in this picture, you can see that I'm getting it infused through a pump into my port. I have a port just below my skin over my heart, and it's got a line that goes right into my heart, so I can get treatments infused directly into the port, which goes right into my central bloodstream without needing to be put into a peripheral vein. And what I love about this picture is that on one shoulder, I've got this experimental drug being pumped into my port. And on the other shoulder, I've got Caitlin supporting me. And I think this is such a good representation of what my journey's been like. Medical technology on one side, keeping me alive, keeping me going. And then the people that I love, Caitlin, my dad, my sisters, my friends, really supporting me and keeping me upright during really tough times. So around that time, I was able to return to medical school at Penn. I took about a year off for medical leave, most of the time in the hospital, some of the time walking laps to build my strength back. But I finally was able to go back to medical school. I was on this experimental drug, siltuximab. I hoped that it would keep my disease in remission. Right around that time, Penn was given a large donation to start the Orphan Disease Center. And so I went to the director of the Orphan Disease Center and I said, I've got an orphan disease. Orphan disease is the term for rare disease. We call them orphan diseases because they're rare and neglected. And I said, I've got an orphan disease. I'm on an orphan drug. Let me be a part of this center. And thankfully, he gave me the opportunity to be a part of strategic planning for the Orphan Disease Center. I was back in medical school for almost a full year on this experimental drug before I relapsed and nearly died now for the fourth time. And what was so tough about this relapse was that for the first time ever, I was now relapsing on the only drug in development, that drug siltuximab. It was the only promising lead. The work that Kazu had done to figure out IL-6 and Castleman disease, it didn't come to fruition for me. It didn't help me. And that was so emotionally difficult to have a conversation with my doctor where he explained to me that there were no more drugs in development, there were no more promising leads, and that this was it. That I would continue to relapse, I would continue to need combination chemotherapy to obliterate my immune system, and that one of these times it just wasn't going to work and I was just going to die. And I turned to my dad and my sisters and Caitlin, who were in the hospital room with me, and I told them, I said, I'm going to dedicate the rest of my life, however long that may be, to trying to find a treatment for patients like me, because it's not just me who isn't responding to IL-6 blockade. There are many of us that don't benefit from this one drug, one half to 2/3 of patients. And you can kind of almost see it in this picture, that this is when I just made the decision that I would dedicate my life to Castleman's. And I was totally laser focused. This was all I would do until the moment my heart stopped beating.
You know, David, if I were going to put a caption on that picture, I would almost call it looking to the horizon.
Yeah.
Yeah. You know, because it's not focused on the person next door. It's looking way out toward the horizon.
Yeah. And that horizon was like this dream. It was like a glimmer of a horizon that like maybe on the horizon, there's some sun out there. Maybe there's some light out there, but it's not right in front of me. And it's not, you know, a mile away. It's on the horizon, but you're absolutely right. And that's the feeling I had. It was that it's unlikely I'm going to find anything in my lifetime that's going to help me, but I knew I was not going to find it if I didn't search for it. And so that was, you're exactly right. It was this sense that there's something on the horizon. I could kind of live out my days in peace, spend time with my family and my friends, and know that there wouldn't be another drug for me. Or I could spend my remaining time fighting to the death, basically, to try to get to that horizon. And I probably wouldn't get there. I mean, frankly, I knew that I probably would not find something that would help me, but I also knew that if I didn't try, I wouldn't find something.
A question came up on chat, and it's a personal question.
Sure.
Did you marry that girl?
I can't tell you. I've got to keep you guys in suspense. TBD, we'll see.
All right. Sorry.
So,
forgive the personal question.
No, all personal questions are okay. I literally wrote a book where I described like the lowest of lows, the highest of highs. I've shared it with the world, so I would be delighted to share it with all of you. So after I made this promise to my dad, my sisters, and Caitlin that I would dedicate my life, the question became, well, what am I going to do? And so there were two things that I did. The first was I returned to Penn for medical school. I took about 2 months of medical leave to recover, but then I came back to Penn and I began to search to see if there were any researchers on campus studying Castleman disease. And I learned that there were no researchers at Penn studying Castleman disease. In fact, there was only one lab in the entire United States focused on Castleman's, and that was in Little Rock, Arkansas. So I decided that I asked a number of researchers if they would provide space to me in their lab to allow me to begin to conduct laboratory research into Castleman's. And this really amazing pulmonology researcher gave me space in her lab. She said, sure, you can use this bench. And she taught me some techniques and said, go for it. And so I set up an IRB protocol and I began conducting laboratory experiments on my own samples. I couldn't get my hands on any other samples, but I could do experiments on my blood. I could do experiments on lymph node tissue that had been pulled out, and began doing studies on my own samples.
Did you have to get an IRB? And for the students, that's Institutional Review Board Research Agreement to be able to work on yourself?
You do. You need to get an Institutional Review Board approval to do any research in the world. And if you're doing it on yourself, it's probably even more important to get approval, because there are a lot of ethical issues with doing research on your own samples, because if you're both the researcher and the subject, the lines can be blurred in terms of what's good for researchers, what's good for the subject. You could maybe draw too much blood, or you could do something, that maybe you shouldn't, like test drugs on yourself in ways that maybe aren't appropriate. So I did get IRB approval to do the research on my own samples. But when I did write the protocol, I didn't say I would be the only. And the plan was that we would start getting other samples, but early on, I was the only patient that I knew. So early on, it was just me. So the next thing I did, I started doing laboratory research. The next thing I did was start a foundation called the Castleman Disease Collaborative Network, because I knew it was unlikely that I would find a solution that could help me on my own. I mean, frankly, I knew that it was going to take a global effort with physicians, researchers, and patients working together from around the world. And so I created the CDCN and began to connect physicians, researchers, and patients to come up with a strategy for how we were going to take this disease on.
How did you find funding?
So early on, there was no funding, and there was no need for funding, because I turned to my classmates from medical school and I asked them to volunteer to be a part of my team. And so it was a small team. There were about 3 or 4 of us to start. And we just started reaching out to anyone who had ever written a paper about Castleman disease, anyone who had ever studied a disease like Castleman disease. We had zero funding, and really early on, it was just about building a network. And I think our first year we raised maybe $10,000, and we spent all $10,000 on research. And so that was what was great, because I was in medical school. I could get my medical school classmates on board with me. We would do the work for free, right? It was free labor. $1,000 on research supplies, on actually doing the studies. And of course, then that 10,000 next year became 40,000, 100,000, and we started being able to raise significant funds. So this kind of gets to this idea of hope. And this is one of my favorite passages, and one of the, I think, something that's really important to me. And so we were chatting about earlier about hope and optimism. So hope cannot be a passive concept. It's a choice and a force. Hoping for something takes more than casting out a wish to the universe and waiting for it to occur. Hope should inspire action. And when it does inspire action in medicine and science, that hope can become a reality beyond kind of what I was talking about. And even the subtitle of the book, Doctor's Race to Turn Hope into Action. I was a very hopeful person, but I also wanted to start taking action to get towards that which I was hoping for.
David, I've observed.
So now I want to transition into, oh, sure, please.
Well, no, I was just going to say, I've observed over the passing years, and advice that I've gotten is, we as physicians, and I'm an emergency physician by trade, 44 years, working in a big, busy center. And we have to be cautious not to destroy people's hope or in any way, eat away at their hope, because sometimes the hope is all they've gotten. Yep. You've been there. God Almighty, you've been there.
Yep. Oh, I totally agree with you. And there's, and of course, you know this well, and all doctors are really trained in this idea of never providing false hope, but also encouraging there to be hope, and finding that appropriate balance, which is not always easy, but it's so important.
Do you pray with your patients?
Actually, I don't treat patients clinically. So I'm 100% research, and I'll share a little bit more about that later on. But so I don't actually treat any patients clinically.
I had a gal come in to see me fairly recently. She was 39. This will be a familiar story to you. She had lymphoma, and she had done everything the doctors had told her, everything. And she had diffuse metastases. She had vertebral metastases. She had vertebral fractures, the drill. And she had done everything, and she was in horrible, unrelenting pain. That's why she was in the ER. And so I just went, we gave her plenty of medicine, a lot of Dilaudid and so on to, make her feel better. And then I just went and sat on the bed and held her hand. And I just said, I don't really have much to offer at this point, but would you like to have a prayer together? And she said, I would like that. Wow. So we did, and sometimes just making people, working to help people feel stronger in their own space is part of maintaining hope, I think.
I totally agree. And I think that, you read the situation, you empathized with the patient, you connected with the patient. And I think that that's what's so important as a clinician is to connect with them on whatever that level may be. And during the toughest times, providing that supportive resource, I think it's beautiful. And whether you're a clinician or whether, you're a medical student in training or a health professional in training, there will be many opportunities like that. I don't have unlimited time for the talk tonight, so I had to cut out a lot of my journey. But in Chasing My Cure, I do talk a lot about some of the really critical experiences during medical school that actually happened before I ever became sick, but that they really have framed who I am, and they've really established the foundation of who I am. And some experiences that before I went to medical school, I never would have dreamed of having an experience like that, and a really a life-changing experience with patients. And as I mentioned earlier, and as I'll get to, I made a decision to decide that I wanted to focus 100% of my time on research and to not see any patients clinically. I felt that my time and my service is best spent being laser focused on developing new therapies and then identifying clinicians who love nothing more than providing patient care and make sure the patient care is provided by my colleagues who love and yearn for patient care and have my time dedicated to where I yearn for discoveries scientifically. So
Wonderful talk, David. Thank you so much. This is great. Keep going.
Yeah, absolutely. Well, you may be looking at your clock and saying, wait, we're 85 minutes or we're 55 minutes in and we're only on bullet 2. But
talk as long as you want.
But we actually, bullet 1, I think, was the longest section. So now the challenges, Castleman disease and other rare diseases. Where were we back in 2012 when I got out of the hospital and we didn't know what was going on for Castleman's? Well, first off, there was about $10,000 a year being spent on Castleman disease before we got started.
No kidding. Are you serious? That was all? Good God.
Totally serious. 10,000, which is really just nothing, right? I mean, literally $10,000 a year grants were going out. The NIH had given $0 to study idiopathic multicentric Castleman disease research. There were no patients in a registry because no registry existed. There were 2 advocacy organizations, but neither of them were working together, and there was no sort of research plan for how to do things. There were no cell lines or animal models, biobanks to research. Many research questions you can imagine that were unknown. There was no diagnostic criteria. So doctors didn't have a checklist to say, these are the things that you have, therefore you have Castleman disease. You had to just hope that your doctor knew what to look for. There were no treatment guidelines to say, this is how you treat Castleman's. There were no blood tests to predict whether one drug or one chemotherapy would work better than another. There were no FDA-approved drugs. That one drug inspired by Kazuyoshizaki was in development, but it wasn't yet approved. But it didn't work for me, and it didn't work for 1/2 to 2/3 of all IMCD patients. So this is where we were back in 2012, and it was really frightening to say, oh my gosh, it was scary to be in the hospital. It's almost scarier to be out of the hospital. So this is a stopping point where we'll take some time for Q&As.
All right, so we have a lot of great questions. So my first question that I have from our students is, do you think that having coming from a medical background made it harder or easier to understand being in the difficult patient situation?
It's a great question. I think that it made it more difficult to be critically ill because as a third-year medical student, you guys will be there very soon. I knew a little bit of medicine, but I didn't know a lot of medicine. And so I knew enough to know that my numbers were really, really, really bad and that I was in the range that I'd never seen before in a patient. But I didn't know enough to really be able to kind of piece things together. And so I think that was a tough time in particular to get so sick.
How did all of these experiences make you a better researcher and patient throughout all of your experiences, would you say?
I think that it changed everything. So, if I had not become ill, then I would have become a clinical oncologist, and I probably would have had a very small fraction of my time that would have been dedicated to research because I really did enjoy patient care. But in my quest to find solutions for Castleman disease, I've become completely obsessed and totally focused on discovering things that the world doesn't know. I like, all I want to do all day, every day is figure out why COVID does this or why Castleman does that and what drugs can be used to solve them. And so I think that it made me, it opened my eyes to research. It opened my eyes to the importance of having drugs available to treat diseases. If you don't have drugs, you can't treat them for a lot of diseases. And I think that it also meant that as a researcher, it's made me a more patient-focused researcher. I don't do research studies because I happen to have samples or I happen to have data. I do research studies because I believe those studies are the studies that are most likely to advance progress for patients.
Right. And how did you bring yourself back from being a patient to going right back into medical school? What was that transition like?
It was really tough. In many ways, it made me more empathetic for the patients that I was taking care of, while at the same time, it meant that I just had a hard time kind of like shifting my mind back and forth from the two. I think that I struggled because, maybe a patient would explain something to me and I would almost like feel it to my core because I'd just been there with them. I'd just been in that ICU, which I think is good. I think it's important for doctors to really connect with the patient experience, but it was really tough.
Right, I bet. What would you say was the most challenging portion coming back?
I think that coming back to medical school after going through the challenge like that, I think it was that before I got so sick, I had this somewhat idealized vision of medical school and medicine, which I suspect some of you guys have a similarly idealized vision that I had. You may not, maybe you're more realistic than I was, but I just kind of believed that like if you got to one of the best medical centers in the world, that they would have answers for you, that would make diagnoses, they'd get you drugs, they get you treatments, and they get you fixed. And I had this belief that you just had to get to the right doctor. Like if you get to the world's expert's got all the answers for you. And then as a patient, I learned that actually for a large number of diseases, particularly rare diseases, the world's expert only knows as much as the world knows. And if the world doesn't know how to treat something, then the world's expert doesn't know how to treat it. And so that was tough for me to swallow because as a medical student, I think it's kind of good to be a bit naive to how far we have to go as a medical system. I think that helps you to deal with some of the challenges. But when I all of a sudden was so aware of just how we don't know everything, that I think made it a little bit harder for me.
Right.
And, David, I think that, the big scourges are still here: colon cancer, pancreatic cancer, breast cancer, prostate cancer. And I think for the students listening, they're going to see astonishing changes in our ability to manage those diseases in the next generation or two.
Yes.
I wish I could be around to see it. I think we're going to see some astonishing things.
I think so too. I think that from a research perspective, I think that we've already, research is about 10 to 15 years ahead of clinical care because it takes a long time to develop drugs. And I do believe we've actually basically crossed that threshold of just kind of the explosion in medicine from a research perspective in terms of how we can profile diseases and understand things on a single cell level. And I think it's going to be in the next 10 to 15 years that those will all translate into drugs, into therapies. So I do agree with you on that.
David, some of these drugs are fabulously expensive. We see the commercials, excuse me, for Humira online for various things like psoriasis and ulcerative colitis and so forth at $60,000 a year, and I would wonder about your perspective, of how we're going to be able to continue to afford stuff like this.
It's a great point. And as more drugs get developed, using all these new technologies like antisense oligonucleotides, like gene therapies, they are even more expensive than Humira's. And so it's a great question. I don't know how our healthcare system is going to afford a lot of these things. The hope has to be that it's such an effective drug that it then lowers costs in terms of patient care. That's the hope. And what we would have to believe is that if the drugs can become so effective, then we'll actually lower healthcare utilization. But you used a great example of a very expensive drug for very common conditions, which means if it's very expensive and it's very common, the total cost is going to be hugely high. The area that I spend a lot of my time in is the very expensive, but the very rare. And so it's very expensive, but it's very rare. So the actual burden to the healthcare system isn't quite the same as a Humira, where it's $60,000 a year times literally hundreds of thousands of people. We're talking $100,000 a year for a few thousand people is more the world that I'm in.
I do a lot of work in end-of-life planning. There's a thing called physician orders for life-sustaining treatment in your state. It's probably called POLST. Okay. And I remember not too far back, I had a middle-aged woman who came in eaten up with colon cancer, bed-bound, in terrible shape, horrible pain. And clearly it was at the end of her life. And I noticed on the chart, it said full code, that she wanted a full cardiac arrest resuscitation, even in this terrible state. Either nobody had talked to her, or, David, it was her hope that she would get better. And so who the hell am I to, in any way? Go ahead, please, Kiana.
Yeah. And then, so another question we had is there some correlation between this disease and cancer? Are patients suffering from Castleman at risk to some cancers than others?
Wow, what a great question. Yeah, we didn't know that until 2016, but a study we did in 2016 revealed that there's a threefold increased risk of cancer among idiopathic multicenter Castleman patients. So whoever asked that question, I didn't even need to do the research 5 years ago. I should have just turned to you and we could have solved it. But yes, there is an increased risk of cancer. As many of you all may know, there are links between the immune system and certainly the ability to prevent cancer. And so, yes, we do see an increased risk of cancer. And I actually don't even think I have it in my slide deck. And just to kind of, I think it maybe speaks to the many ups and downs that I've gone through, but I actually was diagnosed with a rare form of cancer in the midst of this journey, a form of cancer called an inflammatory myofibroblastic tumor that has this ALK4 rearrangement. And basically, I was fortunate enough that it was completely localized to my liver, and they were able to resect it with about 1/4 of my liver. And I just have this, giant scar in my belly, but that's the only evidence left of the cancer. So I got very fortunate. And actually, the reason that we detected it so early is that at the time I was getting PET scans, which is a full body scan, basically to look for highly active cells within your body. I was getting it done every 6 months because at the time that was a way to kind of do surveillance against Castleman's relapses. And in the process of looking for Castleman disease, we discovered this tumor in the liver. And this is, I think, an important lesson, which I talk about a lot in Chasing My Cure. And that's that when they found a giant hot on PET means that it's bright red, found a hot lesion in my liver, the radiologist said it could be cancer, but it's probably not cancer. And then my doctor said, maybe it's something else. Maybe it's not cancer. Let's just look at it again in 6 months. And I stood up to them and I said, why are we doing a full body PET scan if when we find a giant hot red lesion, we don't check to see what that thing is? And so my doctor, the radiologist, they said it's probably not cancer. It could be. Let's look in 6 months. Anyway, I went to a different set of doctors who did a biopsy. They did a percutaneous. They stuck a needle through my abdomen, took out a piece of the tumor, and they confirmed that it's this ALK4 rearranged cancer in my liver. And as a result, they cut out a giant chunk of my liver with the tumor. And I've had no evidence of that cancer. Had we waited 6 months, it may have metastasized and I may have been in an incurable situation. Had we not been doing PET scans every 6 months, we certainly would not have found it until it was in my lungs or my brain. And so this is just, I think, not to scare everyone, I guess, that you need to be doing PET scans every 6 months, but two lessons here. One is that surveillance matters. When you have a high risk disease with big problems, doing the recommended surveillance is good. And two, when you find a problem, try not to write it off until you've fully investigated it.
So, David, well, that's great advice. And so, David, as we're about to head to the second section, one comment from one of the students has said, you should definitely have a TED Talk if you don't already. So,
well, thank you. I have not done a TED Talk yet. I was nominated for a TED Talk right before the pandemic occurred, and TED got canceled in 2020. So maybe a future TED Talk.
So you've been going for an hour. You need a sip of water or anything?
I'm good. I can keep rolling.
Okay, keep rolling.
I'll keep rolling.
We're here until you get tired.
Nice. All right. Well, I promise it won't be too long. So, at this stage, I've given you guys a sense for my journey, the challenges that we were facing, and now I want to kind of shift into talking about progress. So, we had this plan for how we were going to take on Castleman disease, which was starting the CDCN and also doing laboratory work. And one of the first things I wanted to do was to connect with a bunch of other Castleman disease patients. And so we held a webinar similar to this and invited a bunch of Castleman's patients to join. And I did a quick Google image for the word Castleman right before the meeting. And I found this came up on Google image, this Castleman. And so I showed it to a bunch of patients and I said, what do you think about this being our logo? This is a Castleman, what do you think? And they weren't very impressed. They were like, I like where you're going here, but I think you can do better than that. And so we went back to the drawing board and we drew up this new Castleman, which is fierce and is a warrior. And you can see I have the Castleman on my lapel. And so I thought this was pretty cool. So we showed it to our community a couple of weeks later. And then shortly thereafter on Facebook, one of our patients had screenshotted the image and then got it tattooed on his shoulder. And I always say, if this is not patient engagement, then I don't know what patient engagement is. But literally, there are hundreds of Castleman's tattoos all over the world. Our patient community was just waiting for something to get behind. And I think this is just one example of how they've gotten behind what we're trying to do. These are just some of our Castleman's patients. Unfortunately, it affects individuals of all ages. Youngest patient was diagnosed before her first birthday. We have patients diagnosed all the way up through their 60s and 70s. Affects all ages, ethnicities, races, and unfortunately, it doesn't seem there's no rhyme or reason, it seems, for why some patients get sick and others don't. After connecting our patient community, the next step was to connect a volunteer army. So I was a medical student at Penn, and so I turned to my medical school classmates, as I mentioned earlier, to be a part of this effort. And then I finished up medical school and I went to business school at Wharton, also at Penn, and I turned to my business school classmates and I encouraged them to be a part of this. And amazingly, these are just some of the many medical school and business school colleagues of mine who dedicated countless hours towards building and growing the Castleman Disease Collaborative Network and being a part of coming up with a new approach to biomedical research. And here we are doing the Castleman Flex. And again, this is a reminder, do your Castleman Flex, take a picture of it, post it on social media, hashtag Castleman Flex. So once we built that patient community, the next step was to build a physician researcher community. So as I mentioned earlier, me and my friends from med school, we just started emailing any doctor, any researcher that had any affiliation whatsoever with Castleman's or related diseases, and invited them to be a part of an online discussion board and also a meeting that we've been holding annually for Castleman's physicians and researchers. And we've connected this huge network of doctors all over the world who treat patients and conduct research into related conditions. So what's our kind of framework for research? Well, through the CDCN, the first step is really to dissect biology, which really is just a fancy way of saying to figure out what's wrong. What is causing the immune system to get out of control, which immune cells are doing bad things, what cytokines are doing bad things. But the way we do that is we get blood samples and lymph node tissue from patients all over the world. We can send them by telephone or email. We get their samples sent to Philadelphia. We get their full medical records sent to us. So every sample has a full medical history connected to it. And then we begin conducting what's called discovery level and hypothesis-driven research. So that's doing things like proteomics and transcriptomics and genomics to try to understand what's going wrong in these patients. Why is their immune system getting out of control? And then as we learn things about their immune system, then we ask what drugs are already FDA approved that can target that thing. If it's interleukin 6, if it's TNF, if it's IL-1, if it's JAK, if it's mTOR, what are the things that we're figuring out are wrong in the immune system? And then we ask what drugs could we potentially use off-label, which means the drug's approved for one thing and we're going to try it for Castleman disease. Doctors often do that in Castleman's because the disease is so deadly. If you have a patient who's dying in front of you in the ICU, you're going to be more likely to try one of these drugs, even if there's very little data. So we collect that data through a study called the Accelerate Registry, where we actually get a sense for whether the drug's working or not working. The most promising drugs we move forward to clinical trials, like the trial we have what's called RAPID. And then we look at data from the clinical trial and we ask questions like, are there certain ways we could have predicted who would benefit from one drug or another drug so that can further advance care? And then we kind of expand our understanding from the therapeutic side back to our understanding of the disease.
Do you get standard formatting exports of the medical records and other data so that you can enter them into one master data set?
I wish so badly we could get standard, but you know what we do? We request the complete medical record, which typically is sent to us as a PDF online, but it's often boxes of pages of medical records. And then we have 2 full-time data analysts. And actually, this is something that I should mention to all the listeners. We love having people that are applying to medical school join our team at the University of Pennsylvania. And every year for the last 6 years, we've had between 2 and 3 data analysts that go through every single one of those medical records, extract out all the key information into one data set.
Do you do any of it distance-wise? I mean, we have 47,000 kids worldwide that have signed up for virtual shadowing. If you have a need for people, I am sure we could do an outreach, and if you had interest in that, David.
Absolutely. We have a number of volunteer opportunities that would be great virtually. Our full-time positions, we would love for you to be in Philadelphia. We do have a couple virtual roles from our team, but we've got about a 20-member team at the University of Pennsylvania. And over the last 6 years, I believe we've had 14 team members go on to medical school. We've got another handful that are on the team now that I'm sure will be in medical school next year that are going through the process. So it's been great to get some really hungry, hardworking medical students or pre-med students come in, work their tails off, get into great medical schools, and along the way, learn a lot about Castleman disease. And of course, it's not limited just to medical students, any sort of pre-health student. We just really love the idea of having people that are eager to build their knowledge of medicine by being on our team. So not only are they helping understand Castleman disease or the immune system, but they're also growing personally, which means that you're going to have more skin in the game. You're going to want to learn more through these records because it's actually going to help you for the rest of your career. So I would love to go through all of our studies, but I actually am just going to tell you guys, you can go to cdc.org/research and you can look at all of our studies that are underway all around the world. When we started, there was 1 study underway. Now there's over 30. So you can go there and see what we're doing. And now I'm going to transition into the second to last part of the talk, and that's around this idea of personalized medicine. So we made a lot of progress while I was in medical school. This is a picture of me on my medical school graduation day with Caitlin. Graduated from medical school. We got engaged to get married shortly thereafter. So that partially answers one of the questions that came in earlier. We got engaged shortly after graduating from medical school. I started business school at Wharton because I both realized that some of the greatest challenges in the way of progress for Castleman disease were organizational challenges. They were getting people to work together, leveraging resources, working efficiently. These were business problems, frankly. And so I wanted to enroll at Wharton for that reason. I also knew that if I started an internal medicine residency, that I would have had no time to continue my laboratory research and that I would have had to fully focus on residency. And so decided to do a 2-year MBA at Wharton. And just a few weeks after starting up my MBA, I relapsed and I nearly died now for the 5th time. And what was so tough about this relapse was that it wasn't that I was on the only experimental drug. It was that I was actually getting weekly chemotherapy throughout the entire year that I was in remission with the hope that that would prevent a relapse. And even weekly chemotherapy was not able to prevent a relapse. And so I was truly out of options. Truly, even chemo wasn't preventing relapses. This is Caitlin and I actually at our engagement party shortly after I got out of the hospital. So I spent another month in the hospital in critical condition. Chemo saved my life again, but I just knew that this was an unsustainable approach to continue to have relapse after relapse. And I knew that if I wanted to make it to our wedding date on May 24th, 2014, I would need to find a drug that could help to keep me alive until our wedding date. And so I went on a mission. So I'd been conducting laboratory research for all that time and had not identified a drug that had been effective. I had actually identified 2 drugs that turned out to not be effective for me, 2 drugs that we tried during that relapse, but they weren't helpful for me. And so I had already failed twice, but I was out of options. So I really dug in to see if I could figure something out. So what do you do for a patient like me that doesn't respond to IL-6 blockade? Well, these are all your options that are on your screen and all of them have been tried. So okay, well, everything that had ever been tried for Castleman's had not worked for me. So what do? Well, you have to come up with a novel approach. And you can actually check out the paper. I have the link or the citation at the bottom of the screen. But basically from this paper, or from this work, what we found was that we measured a number of cytokines like interleukin-6, these molecules produced by your immune system in the weeks leading up to that relapse. And when we looked at all the data together, we found a couple trends. One was that a marker of T cells being activated began to rise in the weeks leading up to my relapse. And another protein called VEGF, or vascular endothelial growth factor, also began to rise in the weeks leading up to my relapse. And so this suggested to us that maybe T cells were doing something, maybe T cell activation was doing something, and maybe this protein VEGF was involved in some way. And I had stored my samples from that relapse in my freezer. And so I was actually able to go back to them and confirm, in fact, there were highly activated T cells, and there was a lot of VEGF in my samples. And importantly, that was very consistent with my clinical picture. So VEGF is important for blood vessel development and blood vessel growth. And what I didn't mention when I showed you this image earlier in the talk is that one of the hallmarks of Castleman disease is an increased number of blood vessels in your lymph node. And so it would make sense that having high levels of a cytokine that causes blood vessel growth would also be seen in a disease where there's lots of blood vessels in the lymph node. Also, we see blood vessels on the skin. They're called cherry hemangiomas, these little tiny moles that pop up on your skin, but they're actually balls of blood vessels that were popping up all over my skin. And then when you have high levels of VEGF, you also can have extra fluid accumulation. So this could have contributed to what's called capillary leak syndrome, or the really big belly that I had.
Couldn't hear that word. Extra what stimulation?
So extra elevated levels of vascular endothelial growth factor will cause extra blood vessel, extra fluid accumulation. And so that's this sort of capillary leak syndrome. So at that stage, we had some inferences that maybe T cells and maybe VEGF are important. And we pulled together all this data, the proteomic data, the cytokine panel, flow cytometry data, into kind of thinking about a model. What could be at the heart of T cell activation and VEGF production? Is there some sort of common pathway that's involved in these processes? And by utilizing all this data and doing something called pathway analyses, the proteomic data identified a particular communication line in the immune system called the PI3 kinase AKT-mTOR pathway. And that particular pathway is really important for cellular proliferation. It's important for T cells to get activated. It's important for VEGF to be produced. And so the data was kind of telling us that maybe this pathway was turned on. But maybe it wasn't. Maybe it was just an artifact of the data. And so we decided to do a final experiment to confirm whether or not this particular communication line of the immune system was turned on. We did something called immunohistochemistry, which is where you stain tissue for a particular protein of interest. And so we were looking for something called phospho-S6, which is a marker of mTOR activation. So if that particular communication line was turned on, then there would be lots of phospho-S6 in my tissue. And phospho-S6 would stain brown, and counterstain, which is just background, would be blue. And so we looked at a bunch of normal lymph nodes. Again, the idea that maybe mTOR is the problem here. We looked at normal lymph nodes, and you can see in a normal lymph node, there are certainly cells that have increased mTOR activation. You can see there's some brown throughout a quote unquote normal lymph node, but there's a lot of blue. There's a lot of cells that don't have activation of this particular communication line. And then I stained my lymph node, and I was completely blown away by this result. So there was just a tremendous amount of mTOR activation in my lymph node tissue. This communication line was basically stuck in the on position. And this was really exciting because there are drugs, mTOR inhibitors, that are very good at blocking mTOR that have been around for decades. So we hypothesized that maybe mTOR is really the key thing involved in my disease, and that maybe a drug like sirolimus that's been around for decades could be life-saving for me. And so today marks 92.77 months since I've been in remission with this disease. And I say 92.77 months because I know that I can't round up. I don't know if this drug's going to work for 93 months, but I also refuse to round down because I'm so thankful for every fraction of a week, a month, a day, a year. The New York Times called this "Doctor Cure Thyself," which I think is a bit of an overstatement. I think it should have been doctor helping himself a little bit right now, and hopefully for a lot longer. But thankfully, this drug has kept me in a long remission. That picture actually is from my home office with Caitlin next to me. And importantly, we made it to our wedding day. So this is May 24, 2014. Caitlin and I together, my hair grew back just in time for our wedding day. course, it was, such a special moment for both of us. 3 years ago, we had another really special moment when we welcomed our daughter Amelia into the world. I never imagined that I would survive through all of my health challenges, and certainly didn't imagine having a family with Caitlin and with Amelia. This is us at Halloween this past year. Amelia is dressed as Amelia Earhart, and we are dressed as her aviation crew. And if anyone on this call is a parent, you will appreciate the analogy of being an aviation crew versus a pilot. We are constantly trying to redirect our 3-year-old daughter in the right way. And it's just absolutely amazing. Caitlin and I are expecting our second child on November 4th. So that was one of the reasons why I wanted to schedule this earlier on, not too late into October, because who knows when our son will arrive, but we're just really thrilled about that. During this remission, I also joined the faculty at the University of Pennsylvania, where I set up the Center for Cytokine Storm Treatment and Laboratory, or the CASTLE, as we like to refer to ourselves. The CASTLE, of course, focused on Castleman disease and other cytokine storm disorders. And as I mentioned, we always have pre-health students that are part of our program, and would love and welcome individuals interested in joining our team, but also volunteering for us virtually for our COVID work and also for our Castleman's work. I mentioned the Corona Project earlier. You can go to cdc.org/corona, access the world's largest database of treatments used for COVID-19. Anyone can access them. We went on to confirm that mTOR is important across other Castleman's patients. We published it in a number of studies, which I won't go into depth here, but it's been so rewarding to see a drug that, of course, I started out chasing my cure, but now this is a drug that's helping a number of other patients. Patients like Joey, photographed here, who was not responding to first or second line therapy. He responded really well to sirolimus at the Children's Hospital of Philadelphia next door. Patients like Deepa, all the way in New Zealand. Deepa's doctor learned about sirolimus for Castleman disease because her doctor read the New York Times article when it came out and started treating Deepa with sirolimus because she wasn't responding to anything else. She did really well, and she's continued to do well. Neither Joey nor Deepa have relapsed while being on sirolimus. But unfortunately, there are patients like Lisa and Sergio who, despite chemotherapy, despite IL-6 blockade, despite sirolimus, we've not been able to identify anything that could help them. And unfortunately, both Lisa and Sergio passed away, like unfortunately a number of other patients, where this has not helped them. So despite how thankful we are and hopeful we are about how this drug has helped patients like Joey and Deepa, myself, and others, we focus extremely hard on finding more therapies to help patients like Lisa and Sergio.
I was just looking up in the background. I recognized sirolimus, rapamycin.
Yep.
I'd forgotten it's used for transplants to
That's
prevent
right.
overactivation of the immune system. I'd forgotten that.
That's exactly right. So it was developed for transplantation because your immune system, if you were to get a kidney transplant, your immune system would attack that kidney unless you suppress the immune system with sirolimus. And the way it suppresses it is by inhibiting mTOR. And so we literally are just repurposing this old drug in a new way.
We were just I'm pushing 70, and I trained in the 70s, and we were just starting organ transplants back in the 70s where I trained. And, of course, there was a shitload of rejection, as you can imagine. Yeah. Then watched these drugs come, and it changed the whole scope of controlling the immune system. What amazing. Keep going, please.
It's amazing. Yeah, I actually got a chance to meet a few folks from the transplant world who were part of those early studies. And they talked about, what it was like to go from seeing these patients where you give them a new organ, but they actually die because of the organ transplant. I mean, the organ really isn't even able to do its function. To all of a sudden you give the organ, plus you give some of these drugs, and they live a long life. It's just amazing.
This weekend, I had a patient with a renal transplant that COVID killed him. Unbelievable. Just the scope of the set of problems we have to deal with in this complex thing called medicine.
It's so tough.
I didn't mean to interrupt. Please go ahead.
No, absolutely. It's so tough. And so, as I said, we're an hour and a half in, and I promise we're approaching lessons learned. But I wanted to take a moment to talk about this idea of personalized medicine. So what I highlighted for you just now of doing tests on my samples to figure out what was wrong in my case then finding a drug that fixes that exact thing. That's kind of the ultimate example of personalized medicine. Personalized medicine is this concept where you don't just treat all patients the same, but you actually target the drugs based on how that patient presents. And so this is kind of the traditional way. You give everyone with a disease the same drug. Some people benefit, some people don't. But this idea of personalized medicine is that you have the same group of patients, but you run a series of tests so you can figure out which patient is most likely to benefit from one drug or another drug or another drug. And you utilize these various tests to figure out both what drugs should be given and also what new drugs could be utilized for that disease. I'm going to go through this pretty quickly, but I just wanted to highlight a paper that we just published a couple of weeks ago, and it highlights a global collaboration that we did to look into potential blood tests that could be done to predict whether someone would benefit from one drug or another. And I just wanted to emphasize that this was a huge effort with dozens of samples from all over the world. It required 10 different organizations collaborating from Japan to Norway to Little Rock, Arkansas to Philadelphia. And it really was this collaboration that enabled us to make tremendous progress. And as part of it, we were able to do what's called serum proteomic profiling, where we measured 1,300 proteins in the blood of the about 100 Castleman's patients. And then we did things like what's called a Tisney plot, so unbiased clustering to see which patient samples are more similar to one another. And I'm going to go through this quickly and certainly happy to come back to it later on. But basically, we figured out that the lymphoma samples proteomically looked similar to one another. We figured out that the HHV and associated MCD samples look similar to one another. The RA samples look similar to one another. And then we asked the question, what's idiopathic multicentric Castleman disease most like? Is it most like a lymphoma? Is it most like an autoimmune disease? Where on this Tisney plot, what's it going to cluster with? And we were quite surprised to find out that actually the Castleman samples really spread across the spectrum of autoimmunity to cancer. And so there were some patients where there were samples very similar to the cancer samples, and other patients where their proteome is very similar to the autoimmune disease samples, really highlighting this is a very heterogeneous disease. But the next step we did was to just look at the Castleman samples and ask, is there anything meaningful about the proteomic profile of these samples? And in particular, are there patients that are more likely to benefit from one drug or another based on their proteomic profile? And in fact, we did find that this group of patients, what we call cluster 1 patients, had an increased likelihood of response to IL-6 blockade. And then we validated that in a separate cohort. And we actually found that 7 proteins in particular can be measured, and you can predict whether someone's going to benefit from IL-6 blockade or not. Then also importantly, we did what's called pathway analyses or enrichment analyses to look for new targets, things that maybe we could direct drugs at. And interestingly, we found that IL-6 JAK-STAT signaling, which is part of this IL-6 signaling pathway, seems to be important in both people who benefit from IL-6 blockade and also people who don't benefit from IL-6 blockade, which really taught us or suggested to us that maybe JAK and STAT, which are part of IL-6 signaling, are maybe part of the problem in Castleman disease. And so we now have pursued further investigation into the role that maybe inhibiting JAK could have. So rather than just targeting IL-6 with something like siltuximab or targeting sirolimus with something like mTOR with something like sirolimus, maybe there's a mediator like JAK that's involved in both STAT signaling and also mTOR signaling. And maybe you could kind of hit 2 birds with 1 stone. And so we started treating this young patient, Kyla, with a JAK inhibitor about 9 months ago. She's been doing really, really well after spending a whole year hospitalized. And then another patient, Alan in Vancouver, was treated with a JAK inhibitor, and it's been amazing to see how these drugs have helped both of these patients. Again, this is this idea of personalized medicine, figuring out new targets to go after and then rapidly treating patients with them. So, earlier I said I don't treat patients, and I don't treat patients clinically, but I have the incredible honor and responsibility of doing laboratory work to search for new ways to treat patients. And then I speak to doctors and I share about kind of what's on the cutting edge, and they get to make the decision whether to treat patients with these drugs or not. So where are we today in 2021? Well, I'm going to show you on the screen where we were in 2012, and I'm going to superimpose where we are today. So from $10,000 a year for Castleman's research, we've now raised about $1.8 million over the last 9 years. And from that $1.8 million, which we've spent really wisely on Castleman's research, an additional $11.1 million has also been spent on IMCD research. So if you spend really well $100,000 on one study and $100,000 on another study on high impact, high likelihood of success, If those studies are successful, then other groups like the NIH and foundations will then spend millions of dollars to push those studies forward. And so we've seeded research, and altogether about $13 million has been spent on IMCD research over the last 9 years. My lab got the first NIH grant to study IMCD a couple of years ago. We now have a registry with over 1,200 patients in our contact registry. We've unified together into one collaborative network with a unified research agenda, with a biobank. We've answered questions, though many still remain. We published the first ever diagnostic criteria so doctors can check off a checklist to confirm the diagnosis. We've published the first ever treatment guidelines, the first ever blood test to predict whether someone's going to benefit from one drug or another. We've now got an FDA approved drug. That drug, siltuximab, is now approved. It works for about 1/3 to 1/2 of patients. And then we have 2 more drugs in development. The drug I'm on, sirolimus, has a clinical trial going on at Penn. There's also JAK inhibitors that we're also studying in patients as well. So I'm just going to close now with some lessons learned about Castleman disease that we can then apply to other diseases in just these last 5 minutes or so. So this is a picture of a good friend of mine who has Castleman disease when he was in the intensive care unit at the University of Pennsylvania. So he was on a ventilator, on dialysis, in the ICU, getting multiple transfusions a day just to keep him alive. And this is what Castleman disease looks like. And this is a picture of a patient with COVID-19, also on a ventilator, also on dialysis, also in ICU, with multi-organ failure requiring daily transfusions to keep this patient alive. And what I'm trying to highlight here is that at the heart of both of these patients is a hyperactivated immune system. In idiopathic multicenter Castleman disease, we don't know why the immune system is getting out of control. In COVID, we know it's getting out of control because it's trying to fight off the virus. And in doing so, it's causing collateral damage. But as COVID emerged and as it became clear that there were so many similarities between the most severe COVID cases and Castleman's, and then when it also became clear that doctors were using drugs like tocilizumab, which was developed for Castleman disease, we felt compelled to get involved in the COVID-19 fight, particularly as there were questions about, is cytokine storm the right term? And so I wrote an article with Carl June, who really is a world's expert who I suspect will win a Nobel Prize shortly, on this idea of cellular immunotherapy, which can actually cause a lot of cytokine storm. So I had the incredible honor of writing this article for the New England Journal of Medicine on what is a cytokine storm and really defining it, because you can't really argue whether COVID or Castleman's is a cytokine storm if there isn't actually a definition for what is and what is not a cytokine storm. But in addition to doing this work, and I'll skip through this and encourage you guys to check out the article if you're interested. In addition to characterizing what is a cytokine storm, we then asked the question, if this is what a cytokine storm is COVID a cytokine storm? And when we really determined that for the vast majority of COVID patients, it's not a cytokine storm. It's your immune system is appropriately responding, it's controlling the virus. But for those patients who are most sick in ICU, it really does appear to be this hyperinflammatory response, which we call cytokine storm. So anyone and everyone around the world can go to cdc.org/corona, and you can access the world's largest database on all drugs used for COVID-19. I mentioned volunteer opportunities. We've had over 90 volunteers be a part of this throughout the pandemic, extracting data on over 270,000 patients. It's now actually over 500 treatments, all available in an open source database. We're getting ready to launch version 3 next week, which will have an entire new boatload of data that we're in the process of auditing right now. So once that audit's complete, we're going to go live with version 3, and really encourage you all next week in particular to check out the Corona database, where you can see every drug that's ever been given to a COVID patient, and you can make your own decisions about what drugs look promising, what drugs don't look promising. We actually provide grades based on synthesis of the evidence, so you can get a sense for what drugs really do seem like they're working, what drugs really don't seem like they're working.
What's the big trial going on with molnupiravir right now, or molnupiravir?
Yes.
That's a double-blind placebo-controlled trial right now. I don't know if it's Pfizer, I can't remember, but
I think it is Pfizer. It's Merck. It's Merck, but yeah, it's a big trial, and you're right. It's trial.
I think it's a protease inhibitor or something like that.
It is. It's a direct antiviral, and all of us are really optimistic about it. We're super excited about it, because up until now, there really have not been effective antivirals for COVID. There have been very effective immunomodulators. So if you're in the hospital, you get dexamethasone, you significantly reduce the risk of death. If you're in the ICU, you get tocilizumab, significantly reduce your risk of death. If you get baricitinib, which is a JAK inhibitor, again, reduce risk of death. But unfortunately, we haven't yet found really effective antivirals that can be used early on that actually demonstrate clear benefit in large studies. And we've literally looked at everything. And so I have to say that I want every single drug to work for COVID. And I wish all 500 plus drugs work for COVID, but unfortunately they don't all work for COVID. I think it's really critical to have data like this available so anyone in the world can use it. Because I think there's a lot of mistrust of our healthcare system that maybe doctors are looking at things kind of behind veils and not sharing the data. And we said, we're just going to make it all available to anyone in the world to use and see why we grade things one way or another. So my last slide, I'm just going to close with a handful of lessons. Like I mentioned, these are lessons that I included in my book, Chasing My Cure, but obviously don't have the ability to go into all of the key lessons and certainly a lot of my anecdotes from when I was in medical school. And I really do encourage you guys to check out Chasing My Cure. I think that I wish that I could have just read Chasing My Cure without having to go through all the journeys and challenges that I've gone through. And I wish I could have just taken the lessons without all the pain. And so that's really why I wrote this book, is so that other people can just get the lessons without all the ICU stays. So the first lesson is really this concept of overtime. I talked about how I felt like I'm in overtime. Well, the reality is we're all in overtime. And in overtime, it's not to be afraid about our future and concerned about the fragility of life, but it's really to be able to develop some clarity around, well, if we're in overtime, how can I make sure that every step I take is the right step and is the important step that I should be taking? The second is that I hope no one watching this will ever be confused as your father's pregnant wife. But if anyone watching this is ever confused as their father's pregnant wife, I hope you can laugh about that because laughter can be so powerful during really, really difficult times. The third is this idea of turning hope into action. I think it's critically important to be hopeful, but I also think it's really important to then ask, what can I do today to get closer to that which I'm hoping for? How can I contribute to hope becoming action and hope becoming reality? A fourth lesson is around the fact that the drug that I'm on was sitting at my neighborhood CVS and no one had ever thought to try it for Castleman disease. It's been around for decades, but no one had ever made the link to say sirolimus could be useful for Castleman's. How many other of the about 2,500 FDA approved drugs, which are approved for about 3,000 human diseases, could actually be useful for the thousands of human diseases that don't yet have approved drugs? And I think it's really critical because the healthcare system is not set up to incentivize research into these old generic drugs that aren't going to make a profit for anyone. We as leaders in healthcare, and you all as you move forward as leaders in healthcare, need to focus on this idea of drug repurposing to make sure that every drug that humankind has ever discovered for one disease is also used for every other disease that it could be helpful for. And so I've been partnering with the Chan Zuckerberg Initiative and also a group from the FDA called the Cure Drug Repurposing Collaboratory to try to create a path forward to encourage drug repurposing so that, as I said, every drug that humankind has ever approved for one thing must absolutely be used for every other thing that it could be helpful for. We have something called the Roadmap Initiative. And if you email me after this, the Roadmap Initiative is probably where I'll direct you if you're interested in volunteering for us. We are right now going through every single rare disease and extracting data on what drugs are approved for those rare diseases, what drugs are being used off label, what repurposing opportunities are there. So that way we can build out a roadmap that's data driven around how do you get from no drugs to drugs. And we're looking for volunteers to help us with that. So if you email me, I'll certainly be directing you to the Roadmap Project first, and we'd love for you to join us. Like I said, we've got people all over the world helping with the Roadmap Project. So this idea is solutions may be hiding in plain sight, but we need to take on the responsibility of finding those solutions. And finally, the last lesson, my book is called Chasing My Cure, but we really should have called it Chasing Our Cures, because it wasn't just me chasing after my cure. I don't know, I probably mentioned dozens of people throughout my talk that have been a part of this journey. And that's really the key to making progress in medicine is realizing that none of us can do it alone, but we can really achieve amazing things together. And I really hope you all will be a part of this army. We've had this amazing army of people from grad school to medical school to volunteers that have been a part of this. And I hope you all will be a part of that in helping to raise awareness about Castleman disease, about COVID, the Corona Project, about Chasing My Cure, about the lessons that I learned from this journey. I really hope you guys will help to amplify it by following the work we're doing on social media, by checking out Chasing My Cure, and by emailing me about volunteering for our team. So this is just kind of a summary on how you can help with Chasing Our Cures. check out chasingmycure.com. Chasing My Cure is available everywhere books are sold, Amazon, your favorite local bookstore, but you can also get it through the website. Follow our work on social media. Do send me an email if you're interested in getting involved as a volunteer. That's the castle at penmedicine.upenn.edu. And also, please do raise awareness for the CDC and the work that we're doing. So thank you guys so much. I think I'll close it here, and I think we've got some time for some Q&A.
Yeah.
God, David, what a magnificent story. This is, I'm sitting here, I've already gone through 3 handkerchiefs. Terrific. And what a cute kid that you and your lovely wife have had, and with one on the way. We could talk all night, but let's take 2 or 3 questions, Kiana, and then we'll let this wonderful man go back and be with his family.
So we have a great amount of questions, but I think that some that stuck out to me was, do you still deal with any daily symptoms now from Castleman disease or from your medication?
It's a great question. I am just shocked and delighted to share that I've been in complete remission for 7.5 years. I mean, I work full days. I work lots of nights. I raise a 3-year-old daughter with my amazing wife, and I feel the same energy that I felt the day before I got sick. Of course, that's not how I felt for the first 3.5 years I battled Castleman's. I was in and out of the hospital and I felt horrible. But for the last 7.5 years, I feel very fortunate to say that, I wake up every day, and when I take a deep breath, I can feel a little bit of pain at the bottom of my lungs because I've had a lot of fluid in my lungs for over the years, and I have a bit of fibrosis at the bottom of my lungs. So if I take a really deep breath, it reminds me, okay, I can remember where I was and where I am now. If I put my hand on my chest, I can feel my port just below the skin. It reminds me of what I've gone through. If I put my hand on my neck, I feel scars, and in my abdomen, scars from lymph nodes that have been taken out, parts of my liver taken out. So I have daily reminders of what I've gone through, but I obviously so thankful to be asymptomatic.
Do you still have a functional immune system after everything you've been through?
That's a great question.
Depends on your definition of functional. So amazingly so. When I got so sick with my Castleman disease, my problem was that my immune system was too strong. It was literally wreaking havoc throughout my body. And so chemotherapy obviously obliterated it. It grew back stronger, it obliterated again. And though I'm on a drug that suppresses my immune system, I've been very fortunate that over the last 7.5 years, I have not had significant issues of infections. I was obviously terrified when COVID emerged, and my wife and I, didn't leave our house for months. Our sweet daughter, the 3 of us were locked in the house. But because I was very afraid of what would happen. Frankly, I was on an immunosuppressant. I have a hyperactivated immune system. So it was very scary, but I did end up getting the vaccine. And I was also terrified of what would happen with the vaccine, given my crazy immune system, but I tolerated the vaccine well. I recently got tested. I made antibodies well. So I'm well protected. And yeah, thus far it's been functioning much better than it used to.
And then my last question is, what is a motivation or some kind of final thought you want to give to our students who are interested in being in the medical field?
Sure. So I think maybe I'll share 2. One of them is a lesson that my mom taught me, and it's something that really resonates with me, especially during tough times like this, because COVID has certainly been tough on everyone. And that is this idea of creating silver linings. And by that, what my mom meant was that, during tough times, we're often encouraged to find silver linings, encouraged to say, okay, COVID may be bad, but I just spent 3 months, locked in with my daughter and wife. And actually it was pretty awesome. We spent special time together. That's finding a silver lining. But creating a silver lining is saying, in the midst of this really tough time, I'm going to build something. I'm going to create something that's going to make something positive out of something that is not so positive. And so that might be you deciding you want to get involved in the EMS program at your university, or maybe it's you deciding, hey, I want to be a doctor. I'm going to, or I want to be a healthcare professional in any way. And that's creating a silver lining out of something really tough. So encourage you to create silver linings. The other thing that I would say is that it is absolutely amazing what we can do in healthcare and in medicine to help patients. And there are so many patients around the world that are so hopeful about the solutions. And as we mentioned earlier, there are so many breakthroughs that are coming down the pipeline over the next 10 to 15 years but unfortunately, they're not going to happen unless amazing people do amazing work. And so don't go into medicine or healthcare or any sort of form expecting that it's just all going to happen and that, the wheels are turning and the train's coming. These things will only come to fruition. Patients' lives will only be saved if amazing doctors, amazing healthcare professionals, amazing researchers do amazing work, and we work relentlessly for our patients. And so I'm excited about all of you all's interest in going into healthcare. I love the comments. I've been watching the comments throughout this. It really means a lot. But come into this, ready to rock. We need you. Progress is happening on the research side, but we need amazing clinicians to bring this stuff to reality. So I'm excited for you guys to join the healthcare team. And if you in particular want to join our team, I hope you'll email me and we will get you locked in with some of our volunteer opportunities, or maybe you can join our team full-time in one of the jobs that are open.
Well, if you haven't already, please put in this thing, blow up the chat and say thank you to Dr. Feigenbaum for his time and coming on. If you don't mind, Dr. Feigenbaum, can you go to the next slide?
Oh, sure.
Or the next slide.
Oh, yeah, sure, absolutely. And then I'll just give a comment about you can follow all of our work. We post on Instagram at I think it's D Feigenbaum is the handle on Instagram, versus Twitter where it's David Feigenbaum, which of course we have the most challenging spelling ever. But you can also go to chasingmycure.com and you can get a sense for the work that we're doing.
But thank you so much for your time, Dr. Feigenbaum. For students that are still here, this is our QR code for the quiz. It will be due next Tuesday, October 5th at 6:59 p.m. Central Standard Time. And Dr. Fowler, please close.
David, thank you so much. What an inspiring, amazing, difficult talk. I put a comment in chat when you put one of the pathway slides up there. Okay, everybody, memorize that.
Yeah, exactly.
The future is upon us. The international collaboration that you talk about, I do a similar thing. My team with EMS, CPR, traumatic brain injury, and so forth. And international collaborations are just the marvelous way of the future. We didn't have the ability to have smartphones, Zooms all over the world all the time. So master databases that span the world now are the way of the future, and the way of the now and the way of the future. David, we're so grateful. We will have roughly 5,000 people that will view this talk, 5,000 healthcare professionals, each one who will see probably in their career 100,000 patients. 5,000 times 100,000 is 500 million lives that you will have touched with this presentation tonight. So we just want you to know that we're so deeply grateful. And we want to thank you all for coming. We're going to be here if you keep coming back, and we wish you all the best. And on behalf of David and the whole virtual shadowing team, we want to wish you a good evening and a good night. Thank you for coming.
Thanks so much, Ray. Thanks, everyone.